Dr. Dimopoulos.
By the way, do you use injections of anti-VEGF by diabetes proliferative retinopathy? Do you believe in this old story of Avery that if you inject, then we have immediately
I inject anti-VEGF one day before the operation.
Also by
just
diabetic
to create,
proliferative?
Yeah, to create less bleeding during the operation.
Thank you very much.
Okay, so I'd like to thank Dr. Ferretis for his kind invitation today. And does it go which way? Okay. And the opportunity for my talk today was this paper, which was published in Retina in May this year, regarding laser prophylactic treatment for fellow eyes in giant retinal tears. And the authors here had two groups, the observation and the photocoagulation group. And the results, you can see that the incidence of retinal tears and giant retinal tears with macular detachment in the observation group was lower, actually, than the photocoagulation group. But it was higher in giant retinal tears with macular off detachment. And the authors reached the conclusion that prophylactic laser treatment in fellow eye decreased the incidence of giant retinal tears and limits the consequences of diagnosed tears. So that's a bit strange until you go deeper into the paper and you reach the conclusion, and then you see that what they actually mean is that photocoagulation of giant retinal tears decreases overall the number of giant retinal tears while maintains the same number of tears. And also that if you get a detachment from a giant retinal tear, you get it in the periphery and not in the center, so you don't get a macular off retinal detachment. And further down, they say that they didn't check for a retinal membrane, but they advise caution that when you do laser, you could get an induction of PVD, retinal detachment, and a retinal membrane. So you can see that this is a field that is quite confusing. So I would like to try to clear out, if I can. Those are some predisposing factors for retinal detachment. The counter is not counting, so I can talk as much as I can. Male gender, vitreoretinopathies, myopia, lattice, schisis, retinal tears, aphakia, pseudophakia, laser, other surgeries, trauma, severe retinitis, acute retinal necrosis, and detachment in the fellow eye. So when do we do prophylactic laser? We do laser when we have a symptomatic tear with vitreous traction. Can we have a tear without vitreous traction? No, because traction creates the tear. So that's a tear that we should laser. Or when we find a dialysis, we could laser it so we don't get a dialysis detachment. If you have a tear or a hole with an operculum, do you do laser? Some people do, some don't. Especially you do if you have an anomalous persistent vitreous adhesion. If you have asymptomatic tears, the literature is not clear about that. Some people do laser, some don't, and those who don't have a long series of eyes that they didn't alter the rate of RD if they didn't do laser to those tears. Wholly lattice, you don't generally need to do them. Aphakia, pseudophakia, or just for family history of detachment, you don't need to laser those eyes. You don't need to laser eyes with myopic, who are non-myopic, without detachment history, and without retinal detachment in the fellow eye. You don't need to laser asymptomatic lattice, just degenerative retinoschisis, or just myopia. What happens with prophylactic laser in the fellow eye? If you have a phakic eye with lattice, what do? You could do lattice if the other eye has had detachment surgery. You could do laser, but as long as it's not very extended. If it is going to be extended, it's better to do a 360 laser, not just 200 or less laser. And also depends whether there is a PVD or not. If there is a PVD, then there is a less chance to get a detachment. If there's no PVD, then the chance is high, and then you should consider doing laser. But you should also consider that there is still a low chance of retinal detachment, that tears can still appear in normal retina, that there is a limited efficacy of the laser, and today retinal detachment surgery has a quite high success of over 80%. But having said that, there is always the there is always a possibility that you may have a failure of the first surgery. If the patient is not able to see the symptoms, if the patient came for the other eye with a total detachment that he hadn't realized he had a detachment, then it means that the second eye will do the same, so probably it's better to laser that eye. Or if they live in rural areas without access to ophthalmologists, or if they're not going to come for regular checkups, then again you should consider laser those eyes. If you have phakic eyes with a retinal tuft, you don't need to do laser. If you have retinoschisis, you should consider laser if the other eye has had a schisis detachment, and if in your schisis you have holes on the outer layer of the eye. If you have phakic eyes with tears, usually people do laser, but there is conflicting data on the literature. If you have phakic eyes who have had an operation for a vaginal tear in the other eye, the literature says you should do, but when I remember Bill Elwood and Paul Sullivan in movies telling us about a case with a young girl who came for a giant retinal tear and had a surgery which didn't go well. They lasered the other eye prophylactically, and the other eye got on to develop a giant retinal tear detachment, was operated, it didn't go well. So they're not very keen to do that neither. The same thing happened to me as well. Stickler syndrome, yes, is one of the diseases that may have a prophylactic laser. Pseudophakic eyes with lattice, tufts, and schisis, no, you don't need to laser prophylactically. Pseudophakic eyes with tears, yes, because I have two predisposing factors, is pseudophakia and detachment in the other eye. But you should not use it as a prevention before cataract surgery. It doesn't mean, but because there is a history of detachment, I do laser before the cataract to reduce the chance. Pseudophakic eyes with operated giant retinal tears, yes, is the same as with the phakic eyes. What happens with the 360 pseudophakic laser? We can do 360 laser if when we do the detachment we can't find the break, or if we find a break, but according to the link of flow, that break is not causing the detachment. So we suspect there's another break somewhere else that we can't find. We can do 360 laser if you have bad visibility, pore dilation, lens remnants, posterior capsular opacification, corneal opacities. When you have many tears in all 4 quadrants, it's reasonable. When you have giant retinal tear, when we said, when you have acute retinal necrosis, when you want to combine it with your scleral buckle, and when you want to create a second ora serrata. But you have to realize that there are complications with the 360 laser as well. There's a failure to prevent the detachment because tears can occur posteriorly to your laser, or tears can still occur in a normal retina. You can get epiretinal membranes. Rarely you can get transient iris sphincter palsy or affect accommodation, and if there's a lot of laser you do, you can still get visual field defect. So in conclusion, when do we do prophylactic laser? The 2 cases that we need to do prophylactic laser is when you have symptomatic tears with vitreostruction and when you have the fellow eye with the giant retinal tear. All the others are debatable. The doctor must stay up to date according to the literature about what the literature says, because those things change constantly. And the doctor has also to inform very well the patient, not only for the for, but for the cons of the laser, because there exists such things. And also has to use common sense. We don't laser everything we see in our office when we examine a retina. Okay. And we should keep what Hippocrates says. First, we should do good to our patient, and second, we should not do harm. Thank you very much for your attention.
Thank you, Vlassis. How do you advise a pregnant woman that she's going to deliver soon and she's a myope according to her lesions?
It depends. If it's just myopia without any lesion, she doesn't do anything. If I find any lesion like a tear or hole, I laser it.
So, okay. like a normal
a normal person, yeah. Oh, well, no, cesarean, no.
She's going to deliver normally
okay.
and
yes,
not
normally,
C-section.
Yes.
Okay. Yes.
Quick point about lasering fellow eyes of GRT retinal detachments, because there is a systematic review on that, and the conclusion is basically the whole thing is very inconclusive. Right. So maybe doing laser in cases where there is no PVD can create an area where when the PVD develops, you can get a giant retinal tear at the edge of the laser. So basically, that's the main reason that, for instance, at Moorfields, nobody would laser a fellow eye of a GRT retinal detachment. I don't know what you do. If you do laser.
No, I did that, and the same happened to me. I had a giant retinal tear. I did the first surgery, went fine. So I said, since they do laser, let's laser the other eye. I lasered the other eye. 2 weeks later, had a detachment, not with the giant retinal tear, the big tear, but not giant retinal tear. So I don't do it anymore because
one more.
I don't feel safe. Yeah. Yes.
Microphone. Giant tear detachment.
Yes, but he got a detachment. Nevertheless, he had a detachment, so he has to be treated for detachment, yes.
And taking further to what Petros said, Louisa Wickham's paper with Bill Elwood on
to do prophylactic laser in general retinal tears? They say it's impossible to know because you need to recruit more than 600 patients.
Huge amount of patients, yeah.
And it is practically impossible to find that.
Yeah, so it's just something that you have to decide yourself, really.
We thank you.